Welcome to the regular weekly COVID and mental health webinar that has been organised by the Lancet Psychiatry, United for Global Mental Health, the Mental Health Innovation Network and MHPSS.net. As those of you who've attended before know, we've had an amazing opportunity to hear from a wide range of experts from all over the world about the way that mental health is interacting with the COVID pandemic and the responses to it in many complex and different ways around the world. Today, we're particularly going to be focusing on people in vulnerable situations, and we have a great panel of experts here who bring with them diverse experience from different places, thinking particularly in today's webinar about older people, about people who are living in institutions with mental health problems, other different vulnerable groups, and we have a particular focus on today also on India and Sub-Saharan Africa. So my name is Julian Eaton. I'm going to be chairing today. I work for CBM Global, and I also work at London School of Hygiene and Tropical Medicine in the Centre for Global Mental Health. We'll be recording today's webinar, and there'll be good summary notes available afterwards with various links that are relevant for today's talk. We would strongly encourage you to tweet if you do that throughout the webinar, and the hashtag that we use is hashtag COVID-19MH altogether. I'll introduce the speakers in a minute, who will each have a very brief introductory talk about the topic we've asked them to talk about, but we mainly want to have the opportunity to raise questions and discuss together the things that come through your chats and your emails. So I would encourage you to ask questions on the chat box, and those will be sent to me, and we'll be able to ask the speakers those questions. The email, if you want to send an email, is covid19seminars@unitedgmh.org. So without further ado, let me introduce our speakers for today. First of all, we have Katrin Seeher. Katrin is a clinical psychologist who's working as a technical officer at the WHO. She's worked with people with dementia and their families for nearly 15 years. Her current role at the WHO means that she's responsible for implementation of the Global Action Plan and the Public Health Response to Dementia 2017 to 25 and its monitoring framework, and the Global Dementia Observatory. Since the outbreak, she's been chairing the working group on older adults of the Interagency Standing Committee for Mental Health and Psychosocial Support. Welcome, Katrin. Secondly, we have Víctor Lizama, who's an activist for the rights of people with disabilities and an expert by experience. He's currently coordinator of the team of justice facilitators of the Disability and Justice Program of the Mexican NGO Documenta. He's been involved in national monitoring of the implementation of CRPD, the Convention on Rights of Persons with Disabilities in Mexico, and is a member of an international group of justice facilitators and intermediaries. Thirdly, Dr. Sudipto Chatterjee is a psychiatrist based in India. He's got a substantial track record of innovative ways of providing community-based care for people with serious mental illnesses in settings where specialist resources are limited. He's currently working with the NGO Parivartan Trust and with the National Institute of Advanced Studies in Bangalore on issues like effective community services, community engagement, real-life employment, and inclusion of peers and caregivers in financial and social inclusion. And lastly, we have Martin Prince, who's a professor of epidemiological psychiatry at King's College London and director of King's Global Health Institute. His research focuses on mental health and mainstream health and social policy in low and middle income countries and scalable approaches to delivery of evidence-based care. He's an expert on dementia and works on the 1066 Dementia Research Group, but he's actually with us today mainly to talk about his work in the Global Research Unit on Health System Strengthening in Sub-Saharan Africa at King's College London, a project called ASSET. Welcome, everyone. So without further ado, I'd like to get going on this topic. The webinar we have today really came from many comments that have come through the previous webinars and people writing to us and saying how important this topic is. Where there are mainstream responses to a major pandemic like we have now, there are always the risks of certain groups not being able to benefit as much as other people from the efforts of government and civil society in supporting people through this pandemic. So first of all, I want to invite Katrin to speak on the work she's been doing around older people. Please go ahead, Katrin.
Thank you, and hi everyone, wherever you are. In the context of COVID-19, there are three particular areas that that concern me or that worry me, and that's one, older adults are particularly vulnerable, have been identified as such. Only yesterday, the UN Secretary General recognized them or recognized older people as key vulnerable group during the opening remarks of the World Health Assembly. Yet we often find that older adults are traditionally neglected or not focused on in emergency responses. So that's one issue. Second, the measures that are currently used to contain COVID-19 will have effects to access and treatment and care for older adults, and I'll talk briefly about what these implications might be. And then the last part focuses on what long-term implications there may be of this pandemic on older adults and how we might be able to overcome them. So, as I said, older adults have been identified as a vulnerable group. It's important to note, though, that they are particularly heterogeneous and diverse, and there is no blanket statement that all older adults are vulnerable. But if we look at the global figures, we see that they are more often having severe symptoms of COVID-19, and they're also more likely to die of COVID-19. Why is that the case? Mainly because they're more likely to have underlying health conditions, which makes them at higher risk. And also our immune system tends to deteriorate or get weaker as we get older. Another fact that puts them at risk is that we've been informed of outbreaks in long-term care facilities. And as we all know, that the majority of residents in those long-term care facilities are older adults who are care dependent. They rely heavily on hands-on care. So that's putting them at risk also. Now, what have countries done so far? What have we heard how COVID-19 might affect the access to treatment and care for older people? We're all aware of suspension of services, which is worrisome for ongoing pre-existing conditions, but also anything that may develop fresh during the pandemic. We've heard about surgeries being postponed to free up ICU beds or ventilators, and this breakdown or suspension of services leaves older adults and their families and their carers often to fend for themselves. We're also here concerned about a lack of access, or because older adults fear the infection, they're no longer accessing healthcare services. For example, in Italy, there are figures that suggest a 50% reduction in hospital admissions for stroke. In Argentina, the visits to memory clinics have almost completely stopped. So that is a worry. And the third point, I guess, is the reduction in workforce, mainly because existing workforce is used or reallocated for the COVID response. We also see higher infection rates for workforce. And last but not least, especially in Europe, that's been an issue, is border closures have prevented migrant workers that present a large proportion of care for the elderly from entering the host countries. About the long-term impact of COVID-19, we can only speculate at this stage, but given their risk profile, we assume that this is the population group that will be in lockdown for the longest time, which potentially puts them at risk for social isolation for a longer period of time, lack of physical activity, cognitive stimulation, all of which we know are risk factors for cognitive decline, dementia, and also the mental health of the older population. So without counteracting or mitigation mechanisms, we risk to decondition this population group. So what can be done, or what are we focusing on at WHO? Basically, COVID-19 is forcing countries to fundamentally reconceptualize the way in which we can provide health and social care services. The way we want to work or propose to work is working with countries by building on the existing resources that we have, but move them towards technology-based or remote delivery as much as possible to at least maintain a level of services in the time to come. That also requires strengthening the workforce in the aged care sector, which we know are, even before COVID, have been greatly overwhelmed and understaffed in many countries. And last, I would like to finish with what we should do at societal level. And that's for all of us to foster a more positive attitude towards older adults. We've seen an increase in stigma and some worrisome attitudes. So for me, it would be good to just emphasize more the resilience and the positive contributions that older adults can provide in the COVID-19 response, and use their life skills as a way to comfort all of us, and use their skills because they would have overcome other difficult life events in the past. So we should all learn from that. And I think I'll leave it there. Thank you very much.
Katrin, you've brought up some really important themes that I think will come up again later in the discussion. And one of those, Víctor, is the fact that in some of Katrin's comments, she talked about the risks associated with being in an institution. And for many years, a major focus of activism and reform in relation to mental health care has been deinstitutionalization. But it is a sad fact in many parts of the world that many people with severe mental illnesses are still in institutions. I know that's been something that you've been working on in Mexico, and I wonder if you can comment on that, particularly as the Interagency Standing Committee guidelines and the Convention on Rights of Persons with Disabilities all talk about institutions not being places where care should be provided in general, but that we need to understand how to address the particular needs of those groups. So we'd be interested to hear your experiences in Mexico.
Thank you, Julian and colleagues. I prepared this text. The Convention on the Rights of People with Disabilities mentions in its Article 11 the responsibility of the States Party to guarantee the safety and protection of people with disabilities in situations of risk. However, on March 17th, the United Nations Rapporteur on the Rights of People with Disabilities, Mrs. Catalina de Bandas, expressed that not enough has been done to provide guidance and support to protect people with disabilities in the face of the situation of emergency, even that when it is a high-risk group, a concern that is summarized in this phrase: people with disabilities feel that they have been left behind. The abundance mentions that the responsibility of the states is greater towards people with disabilities, institutionalized or deprived of liberty due to the structural discrimination they face, and therefore their situation is even more serious. Sanitary measures that are recommended to contain the pandemic are impossible to carry out for many people with disabilities, since they require different types of support to carry out activities or their daily lives. It is difficult for them to maintain prolonged isolation. They live in the confinement. There are caretakers, or they do not have a home. Conditions in psychiatric institutions generate greater risk compared to COVID-19 due to overcrowding. Facilities are unhygienic. There is negligence in medical care. Food and water service are poor. There are no supplies and care procedures. There is an absence of dignified quarantine areas. Inmates do not have autonomy, and there are no protocols that guarantee the health of people in emergency situations. They have historically been isolated from society, stigmatized and forgotten in their confinement. Failure to respect the right to health and life is not only sending a message of neglect, but constitutes an act of discrimination rooted in state policy. According to data from the Mexican National Mechanism for the Prevention of Torture, in 2018, the population admitted to psychiatric hospitals was 2,682 people. However, this figure is fluctuating and there is no official information available regarding the current number. According to journalistic reports so far, 4 people admitted to the Mexican state of Yucatan psychiatric hospital have tested positive for COVID-19. After filing a legal appeal on April 24, Documenta, the Mexican NGO where I work, managed that the second district judge in administrative matters in Mexico City granted this May 6 a suspension for the federal government to report and implement actions to protect the life, health, and rights of people interned of psychiatric hospitals. This because no health authority has informed or implemented the specific necessary measures that have been indicated by international organizations in the context of the COVID pandemic to care for his highly vulnerable population of contagion. In response, the judge ordered the authorities to protect the human right to health of people hospitalized in psychiatric hospitals, guaranteeing a basic supply of personal hygiene and cleaning of space, as well as healthy distance measures, the performance of COVID tests under the express consent of patients and staff to detect possible cases in order to avoid contagion, the application of health prevention protocols regarding the SARS-CoV as established by the Ministry of Health, the implementation of effective and proportional general sanitary measures for the prevention and avoidability of contagion. The judicial authority also requests guaranteed professional psycho-emotional support for inmates, take the necessary actions so that users of mental health services that have family or social support networks are not involuntarily admitted to psychiatric hospitals, taking into account that this could pose a risk for their health and guarantee contact of the interned people with the outside telephone calls, video calls, or other information and communication technologies. Finally, the federal government must guarantee access to information for inmates, as well as their relatives, about the measures implemented during the emergency by COVID in clear and simple language. These measures shall be applied in the 39 psychiatric hospitals of the national health system that provide in-hospital care located in different states of the country. It is essential that the Mexican government respond to its international commitments regarding respect for the rights of users of mental health services and comply with the recommendations made in the context of the pandemic by organizations such as the Committees Against Torture and on the Rights of Persons with Disabilities from UN, the Inter-American Court of Human Rights, organizations of or for people with disabilities, and specialists. It is urgent that the Mexican government abide by the measures ordered by the judiciary, since people admitted to psychiatric hospitals face conditions that place them at a greater risk. Impossibility of practicing social distancing, lack of hygiene of basic material resources, facilities in poor conditions, barriers to access information, and the absence of mechanisms to access justice, in addition to deep discrimination, stigma, and treatment that violate human dignity. Thank you.
Victor, thank you very much. And it's impressive how much you've managed to do in such a situation of urgency. I think it really demonstrates the importance of how strengthening the disability movement in advance of such emergencies really prepares people to be able to respond to needs when they arise. So thank you very much for that. And we'll certainly be coming back to some of those issues. Quite rightly, the response around mental health hasn't just been around people already affected with mental health problems, but has been thinking very much about the distress experienced by the general population. And we will be coming to that later. I think Martin will be talking a little about that. But before we get to him, I wanted to talk to Sudipto, who has been working for many years in the community with people who have mental health problems. And I wonder, Sudipto, how those people's services and those people's experiences have been affected by the response that the government has made for COVID-19. What's your sense of that?
Hi, Julian, my colleagues and friends. I think it's important to understand that the COVID-19 situation and the set of circumstances that have evolved and are evolving fast have had a fairly dramatic, sudden, and profound influence on people with serious mental illnesses. So thank you, Julian, for raising the difficulties and the experiences of this group of people. I'm also going to talk about the experiences of this group of people in India, where, as you're aware, a very early and a very stringent, robust lockdown strategy has been implemented. And it's only now that we are beginning to ease out of that situation. People with mental health problems, serious mental health problems, also have enduring symptoms, have a range of disabilities that affect their functioning and well-being. And of course, on top of that, there are many barriers to their social participation because of stigma and discrimination. So the situation, even prior to the COVID kind of disruption that has happened, was precarious. And in India and in many other low-income countries, as you know very well, another set of very distressing and serious systemic issue is a lack of access to treatment. For a large number of people with serious mental illnesses in communities in India, there is just no available treatment and care. So on top of this fairly precarious and difficult circumstances, the impact of the COVID disruption has been great in terms of their health, the social, the personal, as well as economic issues that are now becoming more prominent. At a personal level, many people that we work with have said that, like everybody else, they've experienced stress, they've experienced uncertainty, they've experienced a great deal of anxiety about the pandemic, what it means, the rates of infection, and things of that nature. And as we know, that stress in people with existing vulnerabilities does have implications, and therefore relapses have happened for a large number of people. There's also been a sense of compression within their families, which has also led to sometimes interpersonal conflicts and a huge increase in the care burden of caregivers who've been separated from their usual informal social interactions and support. In terms of the health system, the speed and the rapidity with which the health system and supports have disintegrated have caused a great deal of distress in terms of access to care, access to medications, because interstate supplies were disrupted, in terms of access to various group activities that a lot of people with serious mental health problems were engaged in, like drop-in facilities, daycare facilities, and interventions that we run for a lot of people for access to employment. In terms of the health system, this has been really something that we are just beginning to reconceptualize and recover. And one of the things that has happened, as is the case in many parts of the world, is the emergence of the digital medium of treatment provision, to individual consultations, to moving group processes to a digital kind of format. And while that has been useful, while that has serious potential, it's also a matter of concern that this in turn imposes a set of exclusions for people who don't either have smartphones or the ability to access the internet, or in the current situation to pay for those services even. For people who've not been accessing care, who've not had support so far, I think the impact has been equally dramatic, both in terms of some of the personal and family-related issues I raised, but also people do not access services not because they don't want to, but because there are significant challenges and barriers to their access. And I think in this current situation, there's going to be a marked hardening of those barriers in relation to both the felt need for treatment, the family investing in treatment, as well as issues of access. And I think it's important to remember when we talk about people in the community with serious mental illnesses, homeless people who have fallen through all the cracks, all the supports, and are basically living on the streets, are at the best of times a very high-risk group. And in this current COVID situation, I think a lot of them have been in many urban parts of India being taken into migrant shelters and other temporary measures, but a lot of people haven't. And for them, the usual social ecology that they construct around busy places, around markets, where there's access to food, some interaction, safety, those have just disappeared. So I think overall, there is a very dramatic, serious situation in relation to people with serious mental illnesses in community settings. And unfortunately, as happens quite frequently, when the whole system is geared towards the COVID emergency, people with serious mental illnesses have been left to fend for themselves. So there isn't a very organized response to this issue. And I think it's very important that this opportunity is highlighted, that there is a lot of things that need to be done to protect people from vulnerabilities and from exposure to many of the harms of the COVID epidemic. Thank you.
Yeah, Sudipto, thank you. One of the things that for me has been very dramatic is the fact this is a genuinely global experience, and many of the times we struggle to communicate the experience of people in different parts of the world in relation particularly to mental health, but this is something that's affecting us all and is something that I think has in some ways brought different groups together. Having said that, the northern climes, Europe and North America, has really been ahead of the curve in terms of this pandemic particularly, and I think many people are looking to countries that are not yet at that stage. And I want to bring Martin in here, particularly because he's been working on monitoring the pandemic in Africa. And I'd be interested, Martin, to hear from you about what your experience has been in engaging with partners in Africa about what their experience has been so far, and some of the potentially strengths as well as additional vulnerabilities in Africa are in affecting how this plays out for them.
Yeah, so thanks very much indeed, Julian. So we run a health systems strengthening global health research unit funded by the National Institutes for Health Research. We've been working the last 3 or 4 years in Ethiopia, Sierra Leone, South Africa, Zimbabwe, looking at ways in which the delivery of care can actually be improved at systems level for maternity care, integrated primary health care and surgical care. And much of that got seriously disrupted, obviously, in the light of recent activities. And over this period, we've switched our attention to the COVID outbreak in the 46 countries of the Sub-Saharan African region. That's not the WHO Afro region, although there's a lot of overlap. And the reason why we were focusing on Sub-Saharan Africa, we're talking a lot about disadvantage at the moment. And in many ways, these 46 countries share considerable aspects of disadvantage with respect to risk related to the COVID outbreak. So we're looking at this region, which has the majority of the world's least developed countries. It has the majority of the world's fragile and conflict affected states. 38 out of the 46 sub-Saharan African countries are ranked in the bottom fifth of health system efficacy, according to the metric developed by the Global Burden of Disease Group, the Health Quality and Access Index. So that was the origins, the start of our work. So what's been happening with the COVID outbreak in those 46 sub-Saharan African countries? It started on the 28th of February with the first case in Nigeria. By the 15th of May, that has spread with cases in Lesotho to all 46 countries in the sub-Saharan African region. As of this week, there have been just over 52,000 cases and 1,217 deaths. But in the last week alone, there were over 15,000 cases and 298 deaths. So a third of all of the cases in the outbreak and a quarter of all of the deaths happened in the last week. Clearly that there is an acceleration in the pace of the transmission of the epidemic across the region. But as of now, nearly 2/3 of the new cases over the last week came just from 6 countries. It's a concentrated epidemic. Those 6 countries are 5 in Western Africa: Cameroon, Ghana, Guinea, Nigeria and Senegal, and then South Africa in the south. What these countries share is that they're populous nations. They tend to be somewhat more developed. They're relatively highly urbanized and interconnected compared with many other countries in the region. So the outbreak overall is patchy and it's been quite slow to develop. As of yet at the moment, 1.1% of all cases of coronavirus worldwide and 0.4% of deaths come from the sub-Saharan African region, but this region accounts for 14% of the world's populations. And I think the reason for this is that we're seeing a variety of different trajectories across sub-Saharan Africa at the moment. The scenario that we've seen in North America and Europe, a very rapid spread to widespread community transmission, exponential increase in numbers. This actually accounts for the minority of sub-Saharan African countries, mainly those ones that I've just mentioned, that are greatly affected and contributing the majority of cases. We've seen countries where, with early control, the outbreak really never took off. So, for example, countries like Namibia, Botswana, and Eritrea, all of which are soon to be in a position perhaps to declare themselves COVID-free after small numbers of initial cases. We've seen countries that seem to have exerted control after initial growth with 700 or 800 cases, but then a decline in the number of new cases as public health controls bite. Countries like Burkina Faso, Niger, Djibouti, Rwanda, and Uganda. Many countries with slow linear growth, where they're effectively still in the contact tracing phase with limited community transmission, but not the widespread community transmission that you see in high-income countries. So the question is the trajectory of movement towards widespread community transmission, it's just a slower burn than we've seen in Europe? Or is there actually the possibility of flattening the curve and putting the cap on things, nipping things in the bud, if you like, at a very early stage? I think the particular factors in sub-Saharan Africa that might account for this is, first of all, actually, I think the generally low levels of urbanization and the limited interregional connections that exist in many of these countries, and that those interregional connections were relatively easy to close down by shutting a few roads and a few rail lines in a way that in European and North American countries wouldn't have been possible. They've done a very good job of control of imported cases. Most of them have closed borders early. They've put in place effective quarantine measures that we were slow to adopt in the developed north. And they've done very effective control of community transmission, because this is actually one area that sub-Saharan African countries are not really weak on. They know how to control infectious diseases. They've done it with Ebola recently. They do effective contact tracing, coupled with strategic uses of limited testing resources. They trace, they isolate, they test, and they've got community health workers to do that. They also introduce physical distancing measures at a very early stage. But it's important to note that the physical distancing measures in sub-Saharan Africa of necessity look different from those in the developed north. At the outset of the outbreak, the president of Gabon, Patrice Talon, and this got widely reported, said rich countries are putting up huge amounts of money, and some are even resorting to printing notes to prevent what would otherwise be unavoidable socioeconomic chaos. He's talking about the mitigation measures, like the UK, for example, paying temporarily the salaries of about 70% of the productive workforce to keep them furloughed, but nevertheless to keep their jobs open and the companies open. So President Talon said Benin does not have the means of rich countries to accompany mobility reductions or confinements. If we take measures that starve everybody, we will quickly end up being defied and violated.
Yeah.
And the president of Togo, who's also been very vocal about this issue, Faure Gnassingbé, said around the same time, no matter how effective the developed world's approach to the COVID-19 pandemic might be in terms of protecting public health, it simply won't work in Africa without social protection. About 85% of African workers, be they small farmers, street food vendors, waste collectors, transport operators, or nomadic merchants, operate in the informal sector. Many survive day to day, so they'll be torn between staying safe and surviving.
So Martin, I wanted to come back to you on that issue, because we, as Sudipto mentioned and others, the impact of efforts to control an infection is often actually what has a very dramatic impact on people's well-being. We know how important stable income, employment, and the negative effect of poverty is on mental well-being. Have you seen the countries that you've mentioned being able to find ways of particularly targeting the poorest or the people who are most affected by subsistence incomes, to be able to try to target that protection to people who really need it in these circumstances?
Yeah. So I think that the first thing to note is that actually most sub-Saharan African countries, with exceptions like South Africa, Zimbabwe, Rwanda, Djibouti, have not introduced total lockdown. And they've done that for this specific reason. Others, for example, Malawi, have thought of introducing it and have stepped back. In the case of Malawi, because the Human Rights Defenders Coalition, a civil society group, brought a high court action because the government, they had said, had not actually adequately anticipated or sought to mitigate the impact on the poorest groups. What we're seeing from other countries is a wide range, actually, of economic measures that are going to be quite costly. So I think the countries that have done this most effectively have used existing mechanisms in order to boost cash transfers, unemployment benefits over the period of the COVID outbreak. And that's been widely used, for example, in South Africa. A particularly inventive scheme in Togo uses mobile phone cash transfers equivalent to about 30% of the minimum wage for informal workers who are men, and about 40% of the minimum wage for formal workers for women. They've managed to actually distribute that to over 800,000 informal workers in Togo, seeking to mitigate the worst effects. The other things that countries are introducing are food aid packages, and then trying to reduce costs for all citizens by, for example, waiving requirements to pay electricity, water, and other utility bills over the period of the epidemic. But this is costing many of these countries sums like around 5% of their GDP, which many of them are pointing out is money that they don't have. And they're seeking support from external donors. They're also seeking longer term solutions, investment in infrastructure and economy, to allow their economies to actually recover quickly after the COVID outbreak, a kind of Marshall Plan for sub-Saharan Africa.
Yeah, I think this is going to be crucial. The investment in making sure this doesn't become a long-term negative impact on sustainable development goal attainment, for example.
Yeah, and what these countries don't want actually is they don't want debt moratoria, and they don't want writing off of debts. Certainly in the long term, because in the past, when this happened in the early 2000s, it actually led to reductions in their creditworthiness, which then, as a paradoxical effect, actually constrained development in the future.
Thank you, Martin. Sudipto, one of the groups that has been pointed out as particularly affected by this because of the economic impact has been really migrant workers. And we've seen in a number of cases migrant workers as a group who've not been protected very well by law or by employers, and have actually ended up being a source of reinfection into the community. This certainly happened in Singapore. I know that in India, there's been huge challenges by large numbers of migrant workers affected by the lockdown. Can you say something about the way that they've been affected and how people have been able to start thinking about supporting them in that situation?
Well, I think, Julian, you're right. One of the defining features of what has unraveled in India over the last few weeks of lockdown is the image of migrant workers in the informal economy, being seriously disadvantaged, and therefore resorting to fairly heartrending ways of getting back to home and hearth as a response to the insecurity that has been spawned by this crisis. It is a humanitarian crisis by all means, and the numbers are just staggering. To put it in some perspective, 94.3% of Indian economy is generated from the informal sector. And if you take out non-farm labor, well over 80% of the overall economy is the informal economy, where there's limited protection, limited social security, and limited reach of the government to mitigate difficult circumstances like this. So when people with living already in really cramped and terrible conditions were denied any means of income and livelihoods, then the unraveling that has happened has been on their psyche. It's been a collective wound, and also the fact that they feel that they've been abdicated, abandoned by the state and civil society to a very large extent. So in effect, it is going to have implications socially and of course economically. And we know that this is introducing a perfect storm of risk factors for a very large section of the Indian population who are highly vulnerable anyway. So I think there has been patchy efforts at counseling and mitigating some of the immediate social difficulties like access to money and food, but a lot more needs to be done, a lot more needs to be done better. And I think what has also happened is the fact that mental health matters for people in vulnerable situations has been brought home very clearly. And I hope that this is a wake-up call for us to build resources, capacity, like Martin was saying, strengthen health system so that we can respond to an impending mental health crisis.
Thank you very much, Sudipto. I think that's a theme that's come through many of these talks. We've had a number of questions, and Katrin, I just want to ask one from you, which is, I think, going to be our final question, unfortunately. In a similar way to the migrant workers question, the older population is often particularly economically vulnerable, and we've had a question that's asked whether you've seen a difference in the way that different socioeconomic groups of older people have been able to be protected and respond to this outbreak.
At this stage, because we're still very early on in the response, we haven't had a lot of data on this yet, so the analysis is still ongoing. It raises the very important point, though, of collecting disaggregated data for vulnerable populations. So what we always see is that all adults are put in one category, and so the strong message there would be to particularly look disaggregated data for the vulnerable groups and make sure that they don't miss out and are not left behind.
Great, thank you. I'm afraid we need to wrap up now. Our time is short. It's slightly less than an hour we have. So I'd like to thank all of the speakers we had today for your great insights into the work that's going on in all these for these different groups in different parts of the world. I think in conclusion, it seems to me that what COVID has done is really accentuate existing disparities and inequities. And this is a turning point, really. It's an opportunity, I think, for us to be strongly advocating for a post-COVID world where we address these social determinants properly in order for people to be protected from these kinds of risks going forwards, because we know that during times of trauma, those vulnerabilities are only going to be increased. So we need to make sure we put protections in place to make sure that isn't a big problem the next time such a risk comes along for people. In ending, I want to remind people that this is recorded and available for people online to look at later. The next week's webinar is going to be entitled Mental Health and COVID-19 in Conflict Situations, Preparation, Implementation and Recovery. That's on May the 26th. So another situation where some of these risks pile on top of each other and tend to be accentuated in certain populations. So thank you all very much for your participation today. Those who've joined us online, thank you to our speakers, and thank you to United for Global Mental Health and Amy for organizing the technology behind all of this. Bye-bye, everyone.
Thank you.
Bye-bye.